Okay, so my presentation is going to focus on new advances in using food-based formulas. It's going to be a quick overview of the current literature that's available in the evidence base at the moment. Here are my disclosures. So what are the difference between each of these formulas? Depending on which publication you read, they will have different terminologies. So for the purposes of today's presentation, I will be talking about food-based formulas, which are commercial products. They're ready to hang, have about 14 to 13% of rehydrated food and a mixture of soluble and insoluble fiber that are nutritionally complete. Now, your homemade blended diets, these are 100% family foods, and they will have variable nutrient content as you and I would if we were eating different foods each day. And then a commercial blended diet is 100% real food, ready to feed. It's often marketed as organic, and it is heat processed just to help with that shelf life. Now, all of these products are now registered in the pediatric formulas. For today's presentation, I am going to focus more so on the food-based formulas, but I will be alluding to all of these products. And I'll be really clear which one I'm referring to because it is a little bit confusing. I'm going to start off focusing on the homemade blended diets, as the increase in popularity of the homemade diets has really paved the way for these food-based formulas. We now have a number of clinical guidelines to support dietitians and clinicians reviewing these children that are on blended diets. So we've got the British Dietetic Association toolkits, we've got the Aspen and the ESPGHAN guidelines now. Dietitians were heavily involved in all of these guidelines, so they're very practical for the use of dietitians. So this is a busy slide, I'm going to talk you through it. It just summarizes the studies assessing outcomes associated with blended diets. The sample sizes vary considerably, so from 10 to 20 up to 70 to over 400 patients. The studies are generally comparing children on a standard formula to a blended diet, which could be a homemade blended diet or a commercial blended diet. And you can see here, if it's a positive outcome, it's got a positive marker there. If there was no change seen between a standard formula and a homemade blended diet or a commercial blended diet, there was a negative marker. And an asterisk just indicates that it's a significant difference. So the overarching message here is that these homemade formulas and commercial blended formulas are beneficial compared to standard formula. And you can see this particularly so in the upper GI symptoms, but also for the lower GIs. Now, two of these studies did actually look at the microbiome content when they compared a child on a standard formula to the homemade or commercial blended diet. And both of the studies found that both the alpha and beta diversity improved in both these children. I think we all are very aware of how important the gut microbiome is. And it just shows how important it is to have that diverse diet to improve that gut microbiome. So as great as blended diets are, they do have limitations, particularly in the clinical situation. So in an acute clinical setting, we do have a few limitations. So we do use nasogastric tube feeding. So to get a blended diet through a 12 French is very difficult. And often even if you do reduce the viscosity of a blended diet and you put it into a pump, you can get a misreading or an inaccurate reading of the volumes that are going through. So we often restricted to doing bolus feeding with blended diets. And this is due, again, to the viscosity level. And to reduce the viscosity, we have to dilute it, which means it's difficult to meet the energy requirements for children that are fluid restricted, so intensive care and renal issues. Microbial contamination, this is an issue with blended diets as well. I'm going to come on to a paper in a moment just to illustrate this. So children that are immunocompromised, immunosuppressed, neutropenic, we don't recommend blended diets in a clinical setting. And for the same reason, it's contraindicated for post-pyloric feeding because you're bypassing that hydrochloric acid and having that risk. There was a study published about 2 years ago, and it was led by the University of Greenwich that looked at the microbial quality and safety of blended diets. Now, what was interesting was that they found that 73% of studies showed that there was microbial contamination. They also, they believe the reason for this was the number of points of infection risk. So you've got the decanting, so this is why you've got the higher risk of potential contamination. But they interestingly looked at standard formulas as well, and around 50% of standard formulas also had some microbial contamination, which was higher than what I would have expected. It's just something to bear in mind here. So just looking at reviewing the evidence of food-based formulas now, I've broken this down into countries just to help with my understanding. So we're going to focus on North America at the moment. Kate Simella's paper, this is probably the most well-known paper, and she looked at transitioning adults and children with intestinal failure onto a food-based formula. And you can see the children of the participants' underlying diagnosis were gastroschisis, necrotitis and enterocolitis, malrotation. And all of them were on either an elemental or a hydrolyzed formula before they were trialed onto a food-based formula. The mean small bowel length was less than 50 centimeters, which gives you an indication of how complex these patients were. To get onto the study, they had to have chronic diarrhea, and the results showed that 9 out of 10 patients tolerated the transition to food-based formula. The average length of time took about 2 months. I think this is a really important take-home message, because often when we trial patients on a new formula, if they haven't managed to do it in a week or so, we often give up. So I think perseverance and really gradual weaning onto these formulas is important, and to bear this in mind. So the team concluded that the food-based formulas are well tolerated, and it improves storing patterns in patients with intestinal failure. So this study by Cindy Still et al., she focuses in on commercial blended diets. And she was looking at the impact of a commercial blended diet on GI symptoms. And this was a particular, it's an organic plant-based enteral formula. And she recruited 231 patients, of which 180 were children. The bar chart here refers to just the children's results. And you can see that the GI symptoms were significantly reduced in all categories, from baseline to 14 and 28 days post-discharge. And particularly here with the vomiting and constipation, I mean, these are quite impressive reductions, really. The team also noticed that there was a significant decrease in the mean number of health visits required for children with constipation. This study by Gerard Miner, he assessed the efficacy of a food-based formula looking specifically at energy and protein requirements in the neurological impairment children. Now, my colleagues who have presented previously, we have focused on neurological impairment, and on the studies that I'm going to be presenting coming up is also a focus on this cohort. This cohort just does particularly well with this food-based formula with their neuro-GI symptoms, so just to bear this in mind. But the results found that there was no significant difference between a standard formula and a food-based formula for protein and energy intake, so they were comparable. And similarly, the stool consistency and frequency was similar for a standard formula and a food-based formula. So it's just saying that a food-based formula is comparable to these standard formulas, because dietitians get worried about trying out new formulas, and this is just as good, if not better, than standard formula. Now, moving on to Italy now, you may recognize some of the authors here sat alongside me, so I will be very kind about this presentation. This is focusing on 4 very complex case studies. And I'm just going to focus on one of these, which is a child with a newborn with esophageal atresia and complex cardiomyopathy. This child had surgery to close the fistula and had a gastrostomy placed, started on semi-elemental formula. Complications occurred, resulting in necrosis of the small bowel and required a subtotal resection, resulting in short bowel syndrome. The child had ongoing gastroesophageal symptoms, required Nissens, they had growth failure and diarrhea. At the age of 3 years old, the team decided to trial them on a food-based formula, transferring them from a semi-elemental formula. The diarrhea resolved and there was subsequent weight gain and length increased. And the team concluded that a food-based formula for this particular case was effective in the management of short bowel syndrome. Now, my colleagues have already alluded to these papers, but I think it's important to draw your attention to these clinical guidelines that are specific to neurological impairment and the use of food-based formulas. I've mentioned before, these children, they have a number of gastro complications, constipation because of their low mobility, and having this food within their diet just helps with that gastro functioning. The team, they've also submitted an abstract this year to ESPGHAN, and it's a pilot study that specifically focuses on spinal muscular atrophy and using food-based formulas. Now, if you work in North America or in Europe, you'll know that when we treat children with spinal muscular atrophy, we often use an amino acid formula. And this is due to research. This is due to a particular mother in America that pushed this, and some families were very supportive of the amino acid diet. But what's exciting is that a food-based formula has now been used in this cohort of children. So we look forward to getting the full paper once this is published. So moving on to the United Kingdom now, we completed our ACBS approval for a food-based formula in 2020, and the results were really promising. So 94% of children reported an overall positive change in their GI symptoms. And then from this ACBS approval, we were able then to put it in much larger studies, and I was able to lead on a national multi-center study that looked at the effectiveness of a food-based formula. Now, this study looked at 4 NHS hospitals, 3 of which were specialist children's hospitals. And we collected data on 43 children, of which 43% have neurological impairments. 81% of dietitians reported an improvement when they switched from a standard formula to a food-based formula. And you can see here there's significant improvements in all of their GI symptom categories. And 90% of children report an improvement in constipation, where they either reduced medication or stopped their medication for constipation. This publication was only released just over a year ago, but it's already been cited 16 times, which just shows that the interest in this area, and it's very topical for dietitians using this formula. So staying within the UK, I was also able to do some research looking at a prospective study where we looked at the impact of a food-based formula and looking at the concentration of short-chain fatty acids in the stools. We know that intensive care is not a great environment for your microbiome. You've got poor intestinal perfusion, hypoxia, lack of enteral feed causing bacterial translocation, parenteral nutrition, multiple antibiotics, proton pump inhibitors. All of this is causing gut dysbiosis. So we thought it would be a really good cohort of children to use this food-based formula. So we basically monitored children that had been diagnosed with sepsis, started antibiotics, developed diarrhea, and we monitored their stool samples at baseline, and we monitored it weekly thereafter. The results showed that within 2 days, the stool consistency and stool frequency improved. And we also found that the short-chain fatty acids in the stool were maintained. So there might be some protective markers, some protective element of this high-fiber real food product within the gut. And this was also published in Clinical Nutrition. So just moving on from the previous study that I mentioned, which was the National Multi-Center Study, this was a follow-on study, and it's building the real-world evidence. In the UK, we're pretty new to food-based diet and food-based formulas still. We've only had them for about 2 years. So we're just building the evidence base around them. So this was a single-center retrospective study, and we wanted to monitor why dietitians were using these types of formulas. And we collected data on 70 patients, and the full paper is currently under review at the Journal of Human Nutrition and Dietetics. What was interesting about this study compared to the multi-center study was the age group that dietitians were now using this formula. They were using it in much younger age groups. I think that dietitians are just getting more confident with this new formula. Neurological patients, again, was the most common diagnosis or illness that we were using it in, but you can see the range of conditions that dietitians are now using this product. So oncology, cardiology, metabolic patients, endocrine. We also used it in post-jejunal feeding. So 8 patients used post-jejunally, and it was well tolerated. There was no issues from that delivery method. And continuous and bolus feeding. So going back to Antonella's presentation, these food-based formulas are managed with no issues. And again, going back to the blended diet issue in terms of the inaccuracy of feeding when you give it continuous feeding, we don't have that issue with the food-based formulas. So the viscosity is at that adequate level to pass through the nasogastric tube. So there were 106 reasons why dietitians commenced a food-based formula. The most common reason was a GI symptom. So 58 out of 70 children experienced at least one gastrointestinal symptom before commencing a food-based formula. But what was really interesting is that 40 of these 70 were already on a standard formula before we trialed them onto a food-based formula because they had a GI symptom. And almost 50% were on either an amino acid or a hydrolyzed formula before we trialed them onto a food-based formula. So this is a real change of practice for us in our specialist hospital because we're using a food-based formula to correct GI symptoms that are occurring in other formulas. And this is just to highlight that here on this bar chart. So it's the GI symptoms before and after the change. And an area that I'm particularly interested in is the loose stools because invariably children come into a specialist hospital, they have an undiagnosed sepsis, they go into a broad spectrum antibiotic and it causes gut dysbiosis and it causes diarrhea. And a food-based formula seems to resolve these symptoms and it resolves it quickly, like within 24, 48 hours. We've been very fortunate to secure funding to do some more research in oncology. So we're looking to recolonize the gut microbiome in our pediatric oncology cohort. We know that chemotherapy, mucositis, parenteral nutrition has a detrimental effect on our gut microbiome. So we're going to see if we can give a high fiber food-based formula to recolonize that gut. The issue with the oncology children is we can't give them probiotics because they have a central line and they're neutropenic. So the only way we can recolonize the gut is with a high fiber formula. So the outcomes that we're looking at here is to see what recovery we can induce with a high fiber formula. So just to summarize, food-based formulas, they are used in medically complex children with intestinal failure, short bowel syndrome, and other GI symptoms. Food-based formulas are used in children with neurological impairment, commonly used to mitigate their GI symptoms, including constipation and loose stools. Food-based formulas, food-based formulas, they are also used in post-pyloric with no problems, the tolerance there. And clinicians are transferring children onto a food-based formula if they are on an amino acid formula or a hydrolyzed formula that they're not tolerating. So this is a really interesting take-home message and a change of practice for us at the moment. Thank you very much.